This show is sponsored by PowerfulWomenUSA.com. Hey everybody, I'm Jill Conway, and this is Secrets of Powerful Women, a show dedicated to celebrating and supporting strong and successful women and sharing their stories. I'm hoping that you will be inspired to pursue your own dreams, reclaim your voice, and discover your strengths. So my guest today is Dr. Sara Girardi, a top urologist in New York who specializes in treating sexual health in both men and women with a focus on vaginal and pelvic floor dysfunction. So Dr. Girardi, welcome to the show and thanks for coming on.
Thank you. I very much appreciate your having me. Thank you very much.
Oh, this is wonderful. I love this conversation we're about to have because I feel like every woman and every man needs to know what's going on with a woman's body too. So I do want to say this to the listeners. Dr. Girardi has been in practice for over 25 years. She has worked in some of the top hospitals in the country. You're now an attending physician at St. Francis Hospital in Long Island and an associate clinical professor of urology and reproductive medicine at Cornell Medical Center and Hofstra University. And as if you could do any more, you headed the infertility and female urology department at North Shore University Hospital. So if anyone knows urology and this subject, it is you. So we connected because of the Menopause event that I have coming up and you're going to be a part of. But I want to talk about quick, who right now are your clients and, what is your focus on?
So great. Thank you. And thank you again. I appreciate the introduction. I am a urologist who is actually fellowship trained in male infertility of all things. So I did my full residency in urology and then did an extra year in male infertility, which is the field that covers when couples can't have a baby, she goes to a reproductive endocrinologist to find out if it is her, and he goes to a urologist to find out if it is him. And it's a wonderful, very exciting field, and I work closely with the folks in the IVF and all of that. That's where I started. So when I came out to Long Island to practice, that was my specialty, and I got very involved with the IVF team. When I came out, my senior urologist who hired me said, all right, I'm willing to let you do your thing for about a year, but I have a feeling that we have so many women patients in our urology practice. We're all men. I think they'd be really happy to see you. So if you don't mind kind of as a sidebar doing a little women's urology, we'd appreciate it because it's a deficit in our practice. And he said, I'm afraid I think the floodgates are going to open. So you're fine to do your specialty, but just could you do that? And that's going to be our deal. That was our deal. And he was right. So once we opened it up to women, I started seeing women patients. They were so grateful to have a woman physician taking care of their urological needs. Not that the men weren't doing a good job, but they felt very cared for once they saw that a woman had a different approach. And so that has absolutely, that has actually flourished. And so I have actually now really split my practice. I still do see the men, the younger men for fertility, but the bigger part of my practice by far at this point is women's needs, which would include the basics of urology, which is some women have microscopic blood in their urine. That's a very common thing we see, and we have to work that up for women. But we see a lot of women with recurrent urinary tract infections, sometimes kidney infections, and then prolapse, vaginal organ prolapse, where women, anyone who's had it will know anyone who wakes up one morning and says, oh my goodness, there's something down there and I don't know what it is. They get frightened and then find out it is not to minimize, but it is either their bladder or another part that is just low because they've had children, vaginal deliveries, etc. And then another big part is incontinence, the loss of urine, and that can occur in different situations. So my practice now is all of that. And then a little sidebar, which is more recent, is that we are trying to address women's menopausal needs more effectively. And we opened that up in the past few years, and that has also just flourished because there is so much need. And for whatever reason, oftentimes the gynecologist or the general doctors are not addressing that. And we can get into that, but there's reasons for that. So we are addressing that full tilt.
Well, and I think that's so important because as I mentioned to you, I already said I'm coming to you and I'm very open about, my own issues and things like that. I'm 53, I'm postmenopausal. I was having UTIs, chronic. And when I went to the doctor, I love my doctors, but I went there and they were like, well, This is what it is. Maybe you'll just have to go on, low dose antibiotics for a long term. And I was like, there's has to be something more than that. And so I want to talk first about midlife women and the things that you're seeing, that so women listening saying, oh my gosh, I'm not crazy. I'm not crazy. What do you
Correct.
see?
So that we see an awful lot of a routine visit for me in my office hours will be the person with recurrent urinary tract infections. And what's interesting is she may or may not have ever had an infection before. So I'll take the kind of clean one that's just so frustrating for the woman, but I'm sure this will resonate with your audience. I get women in who are in their menopausal years. They'll say, I never had an infection in my life. My first infection was last year. I'm 54 years old, but I don't have one, Dr. Girardi. I've had three. Look at this. And they'll
Right.
show me the pages of cultures and say, I don't get this. And furthermore, I didn't even know I had it. I went in to see my doctor because I was having sort of a vague burning sensation or my urinary pattern had changed. And then they told me I had an infection. I thought, seriously? I thought that was supposed to be all about pain, etc. So someone can have the traditional symptoms, but what I tell them is, listen, menopause is a whole special time in our lives and things are different. So take the individual who did have them when she first became sexually active, for example, and those younger women, 20s, 30s, there are college kids come in and they're in agony. They're in so much pain. They can't get off the toilet. They're in pain, pain, pain. And they take one dose of an antibiotic and they feel fabulous. Very different from our menopausal women. For them, it can be pain, it can be discomfort, but for many it's more subtle. They'll say, I know because there's an odor. I know because I'm off. I know because I get this low back pain. I know because my urinary pattern changed. All of a sudden I'm leaking. I think, oh my gosh, I just lost urine. I didn't even know I had to go. I know because I only get up once at night normally, and now I'm getting up 5 times. They go to the doctor and they get their antibiotic. They go home. They take their antibiotics dutifully. They follow the rules. They go back. 10 days later, they've got it again. What's going on? What's going on is we're not getting to the heart of the problem. And the heart of the problem is the lack of estrogen vaginally. And finally, that has a name. It changed names recently. The name used to be something called vulvovaginal atrophy, VVA, and now it's called GSM. And GSM should be something, if people are writing notes, GSM is an important one. GSM, which is genitourinary syndrome of menopause. And what it refers to is the fact that we need to recognize in all women that the menopausal shift, and there's so many things we can talk about in menopause, and this shift, whether it's the transition, they're still getting their period, but it's a little off, or they're fully in it, no periods, and now they're starting to experience other symptoms. In that setting, there are genuine consequences to the vaginal area. For some women, it'll start to become painful to have sexual intercourse. And that has a whole, we can talk about that as well, but that has a whole added layer of stress. It stresses relationships. It becomes very difficult because they do want to participate, but it's painful. And the partner doesn't want to hurt her, and she doesn't want to offend the partner. And it gets very messy psychologically. But painful sexual intercourse, recurrent urinary tract infections, absolutely one of the hallmarks of the of menopausal condition and GSM. And then discomfort. And I describe it as I say to them, it's called, I call it an unpleasant awareness. They're aware of that area, not pleasant. It's not pain. They can function, they can go to work, but they're not comfortable and they don't know what it is. And they go back and forth to their gynecologist, and many of them come in and say, I was convinced I had an infection. I was shocked that I didn't, because what else accounts for this discomfort I'm having? Lack of estrogen, lack of estrogen, lack of estrogen. So when we restore estrogen, and we're not limiting this to perimenopause in our 50 and 60-year-olds, this is important and especially important in our 80-year-olds. We need it in women all the way through, because I'm sure also this will resonate with your audience. There's at least one, if not a dozen women out there who have been to the emergency room with their dear mothers or their mothers-in-law who have had an infection that went straight to the blood and they've had urosepsis. And that's actually a lethal condition. And it is totally avoidable if these women were instructed from the time they go through their menopause to use a small amount of vaginal estrogen. They can prevent that occurrence in many cases.
Even at 80 years old, that they can use this
Even
and
at
they
80,
can.
especially at 80 years old. I put an especially on it because it is that effective. What does it do? Physically, the science is very clear. when we go through our changes, the pH changes. Vaginal
Yes.
pH is very, very important. And when we're in our reproductive years, our systems are built so beautifully. I mean, the native system is just beautiful. It's so well designed. And in our reproductive years, the vaginal environment is very acidic, and it neutralizes the semen in all toward effective reproduction. But when we lose our estrogen, we lose that pH advantage, and the pH rises and becomes more alkaline. And the bacteria love that environment. Furthermore, we lose our lactobacillus, which are our good bacteria. We have some very good bacteria that inhabit the vaginal canal and keep everything acidic. And when we lose that bacteria, again, the pH rises. Those lactobacillus, which are like guards at the gate, they disappear. So it's like a big welcome sign. Please come in and infect the area. We're all here for you. So it's very supportive. So if we can restore the pH to a low pH, we restore the lactobacillus, we restore the pH, and that alone, we have many, many women who come and say, I can't believe this dab of estrogen, and I haven't had an infection in 2 years.
Oh my gosh. Now, can you also, if you're already on HRT, can you add that into it
Yes. So what
or?
I do is absolutely. So we have some women. So if I see them for a urinary tract infection, I will ask, and I will ask because we also offer, as I said, as part of these sort of menopausal offerings. I'll say, now let me ask you something. Did your gynecologist? I never step on the toes of gynecologists, and I never interfere with that relationship because many women
Mhm.
absolutely love their gynecologist
Sure.
or obstetricians and gynecologists. And sometimes they'll say, listen, I love my doctor, but they never mentioned this. So, and I say, fine. So let's just make it, and I'll recommend it. And then we'll see if they give us their blessing. And then the patient has to decide how they want to manage that. But if they also are having kind of the hot flashes and all that, I say, oh, no, no, no. Actually, I went through horrible night sweats and all that. I had all those menopausal symptoms. And my gynecologist did start me on a patch or some estrogen to calm that down. And I'm good there. I say, okay, but you're still getting your infections? Yes. I say, well, listen, I'm sure your gynecologist would not mind if we added that little local estrogen because you just may need a more direct application of estrogen. So those two things can be done in tandem, absolutely without any concern.
I think so for so many women I know, it's an embarrassing problem. They don't want to often talk about it, but I mean, there's like memes and jokes about it on social media how women can't go running without some sort of pad, or they can't go on a trampoline or laugh too hard. And we're kind of, I feel that's the way it is. We have to kind of suffer through this age,
Yeah.
which I feel like it's freedom and it's wonderful, but at the same time, you stop having a period and then you have to deal with all this stuff,
Yeah,
you know.
I agree with you completely. It's why do we accept this? I must say, at the base of all of this, or for me, the great mystery out there, one of the great questions is why do we as women, we tolerate and withstand so much? And I think it's part of our DNA. I think, as mothers, as if we're parents, but as women, we tend to be nurturing and tend to put other people's concerns ahead of ours. So there's always something, whether it's an ill parent, whether it's an ill child, God forbid, whether it's a sister or brother, somebody needs us. And we tend to say, you know what, I'm just going to put my stuff to the side. We see it all the time. And so I always wonder, why do we withstand it? And you have some women, and it's always different. They'll say, listen, I'm the one in my group. I got a big friend group, but I'm the guinea pig. So I said, I'm not tolerating this anymore. So they'll come in and say, what are the treatments? We should not accept leakage as just a part of life. Come on now. Absolutely not. They're so treatable. So when it comes to incontinence, it's very, very clear. It's not always this clear, but it usually is this clear. There's kind of two different types. And some women have both, and some women have one or the other. The two types are pretty simple: stress and urge. Stress and urge. Stress incontinence is the one that we've referred to for the person who has it when they cough, they sneeze, they laugh, they play
Mhm.
pickleball, they do dancing, they do jumping jacks. And they often give a story like, oh my gosh, Dr. Girardi, I was at a wedding. It was so embarrassing. I had my dress. I just got crazy on the dance floor. I had a couple of drinks. And oh my gosh, I literally had to spill a glass of water on me just to pretend that I spilled a glass of water because I actually leaked. And it's terribly embarrassing. That's stress incontinence, strictly with cough, sneeze, laughter, tennis, pickleball, jumping jacks, and they have abandoned, and trampoline, and they've abandoned those activities because they're so ashamed and embarrassed about it. The other one is urge. So they say, no, no, I'm okay when I cough, sneeze, laugh. I can play my tennis. I'm all right. My problem is when I get off the tennis court and I get in my car and I drive home, I get to the door. They call it the keys in the door phenomenon. And I didn't even know I had to go. I get to the door, I start to turn the key, and I think, oh my gosh, I have to get to the bathroom. And they open the door and they run for the bathroom and they can't get there in time. That's called urge incontinence. And it becomes a joke. It becomes a joke in the family, like, oh, mom's home, clear the
Right.
path because she's got to get to the bathroom. They are treated differently, but they're both very treatable. So no woman should expect or accept that leakage and pads and incontinence pads are absolutely going to be part of their future. And just because their mom had it, or their grandmother had it, or their maternal aunt had it, that they have to accept that. Absolutely not. At least be evaluated, because we have great options for all this stuff now. We really do.
Wow. So the stress one, how do you treat that? You treat that with the
So, yes.
estrogen?
So, what's exciting about this, that can help. That helps both types. So,
Okay.
estrogen cream, if somebody already has some vaginal dryness, they're having the painful sexual, all that, I say, let's start with your estrogen cream and I always want to get the infections under control first,
Hmm.
because they're just going to mess up anything anyway. So, I say, listen, if you've had recurrent infections, let's get that cleaned up first. And once we have a good 3 month or 6 month stretch without infections, let's treat the other part. So, let's say we manage that, or it was never part of the picture. The person who comes in with stress incontinence, today I probably saw half a dozen people, and they say, I'm leaking when I cough, the trampoline, whatever it may be. They come in and we examine them, and it's usually a pretty easy diagnosis. You're up in the stirrups, and I will ask them to not have emptied their bladder before I see them. We use a little half speculum, comfortable, and just say, give me a big cough. And I go like this to get out of the way, or I bring my umbrella, and we look. And if there's a little leakage or a lot, we have our answer. Literally in the books, they'll even accept that as okay, now they're a candidate for treatment. And the way we manage that stress incontinence, now at the same time, we're doing a little more than that. We'll also check to see that the woman doesn't have other so called prolapse. Is there a weakness where their bladder is also coming down? Is the uterus starting to come down? Is the rectum starting to come down? Because that gets a little more involved. And we might say, you may need a bigger sort of surgical correction. But if it's just that urethra, they leaked and everything else looks well supported, we now have a wonderful newer treatment. Across the country, a sling, which is a sloppy term that's used incorrectly often, but a midurethral sling or mesh is used in this application and has been used for, I don't know, I started doing this 25 years ago. It's still across the country the standard of care. However, we have something that I think is better or should be offered first. And I'm choosing my words carefully, because the sling is still the standard of care. What does it involve? You have a urethra. When I examined that woman, I'm looking at her and I asked her to cough, and the urethra moved like this and the urine came spilling out. A sling is wrapped around the urethra so that the next time she coughs or sneezes or laughs, there's a backdrop of support so it doesn't just swing down and leak. And the slings they're wonderful, and there's different ways to do it, and people have different approaches, always in ambulatory surgery, and they're back on their feet rather quickly. But mesh is a foreign body or a foreign material. There are some side effects, so it could be too tight and might have to be adjusted. And mesh got kind of a black eye back in 2009 and 2010. There's a lot of controversy surrounding mesh. So we'd like not to put foreign material in women if we can avoid it. So right now there's a really wonderful newer procedure, not a new procedure, but a new material. So what I'm saying is years ago, 50 years ago, there was a procedure that was often done in men, and it's a urethral bulking. So if I depict the urethra this way and the urine is coming spilling out like this, we can put a little gel, an injection of gel at 10 o'clock and 2 o'clock and 4 o'clock and 8 o'clock, creating a swelling and a swelling and a swelling and a swelling. So it ends up looking like this, like puckered lips when we're finished. It's done with the patient a little awake. We fill the bladder very full. She doesn't feel the injections, but I then ask her after I've done that, okay, cough for me now. She's drowsy, but she can cough hard. And if there's no leakage, we're finished. She goes to recovery and she can literally exercise the next day. If there's a little leakage, I'll go back in and fill in that spot, and she's finished. No mesh, no general anesthesia, no stitches, no cutting. So a tremendous advantage. Now, is it exactly as effective as the mesh? No. The slings mesh, 95% successful. This is more like 91% successful, but I now have shifted my practice and said, I feel obliged to offer that in all women first, because if I can spare someone mesh, I think I've done them a service. If it doesn't work perfectly, we always have the option of doing mesh afterward, but I like to offer that first. So that's pretty much how we manage the leakage with the cough, sneeze, laughter, tennis, trampoline.
Now, does that interfere with sex though?
No, it helps it because some women are very self-conscious. They're not sure if they're leaking during sex, called coital incontinence. But some say, I don't know, I got some moisture, and there's a lot of we don't have to get into
I
this, but
love your honesty. I love this conversation. Go ahead.
yeah, there's a
Yeah.
lot of controversy. Some women say, sort of, all right, this may be TMI, but I have a question for you. Do women have an ejaculate or don't they? Because there's something happening. There's moisture when I'm not sure what it is. And I say to them, listen, there's a little bit of controversy. Some people absolutely believe that there is such a thing as a female ejaculate. There are glands there. It does make sense that it can occur, but this is something that is unfortunately, it becomes a centerpiece to certain sort of pornography and things like that. So, unfortunately, if we get into the realm of what some women have they develop unrealistic expectations. It's unfortunate. They have material, or their partners, in my mind, irresponsible partners, will sometimes make expectations on their female partner that are unreasonable. So, I object to that. When there is moisture during, it's often urine. It really is, and women feel ashamed to admit that that's occurring. But sure, it's occurring because it's the same process. You're going to be hitting up against the bladder, and you have a weak urethra. Yes, you can have leakage. So it's called coital incontinence. Very embarrassing for women. They hate to admit it. They'd much rather talk about their tennis game and how it occurs there, but it can happen. So it can enhance sexual intercourse in the sense that they feel much more comfortable, that they're not having any issues with leakage, and they feel much more confident, much more feminine, much more appealing.
So this isn't really a bladder issue then,
No, it's
which I had
urethra.
thought.
Yeah, it's really
Yeah.
the urethra. Yeah. Good point. Unless it's associated with a low bladder. But no, it can occur in isolation and often does, and is very treatable in isolation. Yeah.
So what is your thought on Kegels? I mean, do they even work?
They do. So I do think command of the pelvic floor is important. Now, if somebody comes in, we grade that urethral mobility 1, 2, 3 in order of severity, with 1 being mild and 3 being severe. If the woman coughs and the whole wall there is really coming down significantly, pelvic floor exercises are probably not going to reverse that. So I always say to women, if they want to make a concerted effort to do that and to strengthen those muscles, it will always help. Can it change it from a severe problem to zero? Not likely, but maybe. I always encourage that. Sure, always go with the conservative measure first, and especially with slings, because the mesh, I thought, do pelvic floor therapy first, because the sling is a commitment. With this Bulkamid, I feel so comfortable with it that it's fairly innocuous, that is okay. So, but I think the pelvic floor exercise is so important for you to have a good command of your pelvic floor and to understand how it works. And I will say one thing: pelvic floor exercises in conjunction with weight loss. So if someone is very heavy, the weight loss helps enormously. And that combination, I have seen women go from significant incontinence to dry when they combine their weight loss with their pelvic floor exercises. Absolutely.
Wow. So when you get that procedure where you do the injections, do you have to come back? How often do you have to come back to get those injections?
No, so
I would
no.
imagine it's not a one-time thing.
Yeah, so no, actually, it should be. And this is, I always say to my patients, because it's relatively new, it's not brand new. It came out to all of us as urologists probably 4 or 5 years ago to use, but the researchers brought it to research in 2014, and they studied a subset. They studied women here and in Europe, and in the 2014 studies in both countries, where reportedly the 91% are still dry. So that's a really good track record. That's 10 years of data. I always say to the patients, I'm very honest, very transparent. I say, listen, this is what we know. I'm giving you all the information I have. You can look at the same studies I am. And so we consider it to be 91% successful. The jury is not out on what's going to happen after 10 years, but I expect this to work. Now, I also caution them that so it's 91% successful. And I always use this patient as an example because she's so funny and I love it. When she came in to see me, she said, okay, here's my story. She was this little firecracker. Just everyone has somebody in their lives like this. She's about probably 5 foot even, and she's super athletic. And she said, when I play tennis, I go hard. I go hard. And she kept saying how she goes hard. I think she's a very fine tennis player. And she was so full of energy. So I could just imagine what she's like on the tennis court, in her 40s, I think. And she was soaking 3 pads. I mean, she looked like she's wearing a diaper. And she said, look, and she's this big. It was so upsetting to her. So when she came to see me, she had very significant incontinence. I said, listen, let's do this. But I have a feeling, let's see how it works. You're so severe. You must be prepared for a second procedure. We may get to be, get 80% successful, but if we have that little last bit, she said, listen, if you can get me even out of one of these pads, I'll be happy. I'm so miserable. We did the procedure and she was 95% successful. She came into the office. I see them at 2 weeks. And then I hope I don't have to see them. Not hope. I hope they don't have to see me again. 2 weeks. And when she came in, she said, okay, she was thrilled. Big smile on her face. She said, I'm down to a liner, but I'm so sick of these pads and I'm so grateful. Is it selfish and silly for me to consider doing it again just to get that last 5%? I just want to abandon these pads. I just don't want. I said, no, this is up to you. You saw the procedure. It's pretty innocuous. And I do think a second time will do it. And what's interesting for me is when you go back, you can kind of see your footprint. You can see where you were. And I said to her, this is going to be interesting for me because she was one of my early in my experience. So I said, I'm kind of interested too. Let's see when I go in. And if I see where there's a little gap, I'll just fill it in. That's what we did. She's bone dry now, no pads, and she's playing her tennis. So we don't know. But so far, I mean, they do have the data from 2014. It appears to be consistent. And I just tell my patients exactly what I said to you. I'm totally transparent. I said, look, I know what I have my experience and I look at the broad experience. And so far, this is what we have so far. So when they do it, they say, it was a pretty simple thing. I just had to, basically, you had to spend one Wednesday over at the day op center. And that was it. So it wasn't so bad. So some of them have done a second one. Very few, about 6% do a second procedure.
So I know a lot of women who it's commonplace for them to say, I wear a panty liner every day of my life. And to you, you say what to that?
So I say, what for? And some will say, well, I get a little bit of a vaginal discharge because I'm prone to yeast infections, or I get a little bit of staining here and there because I have a long history of endometriosis or something. So it depends on what they're wearing it for. But if it's for their urinary, because it's urine, I'll say to them, how do they feel? Does it bother them? And it really is, all of this is about bother. There's no
Oh, I
shoulds.
think we're losing you for a second. Wait, repeat that part. Wait,
Okay,
repeat that part again.
sure. So
If they
yeah,
say if it's urine, yeah.
if it's urine, I say to them, does it bother you? It's all about bother. And I'm not in no position to judge. So I have some women who have a drop of leakage and they are flipping. And when that happens, and it's always interesting to me. So they say, I say, how much is coming out? Because for some they're soaking pads and they'll say, oh, I saw a drop. And I think, why is that so? I mean, I understand you don't want to have a drop, but it's a drop. It's not a soaking. And oftentimes that will be informed by some experience. And oftentimes it's that they have a mother or a grandmother or someone in their lives who ended up with very severe incontinence. Perhaps there was an odor. Perhaps every time they went into their grandmother's living room, there was a smell. Something is making them worry that little drop is going to lead to something worse down the road. So it's all about bother. If a woman comes in and says that one drop bugs me to death, I say, fine, then we'll take care of it. There's no judgment. And I have others who come in and they're okay wearing their pads and they're okay wearing their thick pads. I don't like it for them. And I never twist arms, but I will say to them, listen to me. The only thing is I'm going to stand by and allow this. However, but you need to see me regularly because I will not abide or stand by. If the skin starts to break down, that's a disaster. And if they start to get urinary tract infections, that can lead to severe problems. So I have to step back as their urologist and say, listen, I don't advise you to continue along this path. I really want you to pursue treatment because this leakage, although you may not be bothered by it, it can lead to other problems. And the tricky one that's sensitive, but with a good family member, we can do it, is sometimes the mother who has lost some of her sense of smell has a strong odor and the daughter brings her in out of sheer just sympathy for her mother and doesn't want her to embarrass herself. And so that's another one. It's just, this is such a terrible problem in some cases. The mother no longer wants to visit with the family because she's afraid that she'll have an accident when she's sitting on their beautiful new living room furniture. There's things like that are just heartbreaking. And so that's, to have that the patient herself or a family member there to say, I think mom needs to do this and we want to help her to this solution.
This is so incredibly interesting, and I think every woman needs to hear it. So let's take a quick pause here. So much more to talk about. We'll be back with Dr. Sara Girardi after the commercial break. You're listening to Secrets of Powerful Women. Stay with us. Hi, everybody. I'm Jill Conway. If you love what you're listening to, please like and subscribe to my channel on whatever podcast platform you listen to and on YouTube, so I can keep bringing you these amazing women and sharing their stories. Thank you so much for listening. I hope you love it as much as I do. Welcome back, everybody. You're listening to Secrets of Powerful Women. Dr. Sara Girardi is with me, a top urologist in New York who specializes in treating sexual health in both men and women. She focuses on vaginal and pelvic floor dysfunction and so much more. So, Dr. Girardi, thank you again for having this conversation that I think every woman needs to hear. So we were talking about women in incontinence, stress, and urging, and the difference. And I know you had more things you wanted to add to that.
Yes, I just want to just say that. So the stress incontinence, we have wonderful options for that, and thankfully they've gotten better and with fewer side effects and complications. The other big topic is if it's not happening with cough and sneeze, but the person says, no, I'm more the person who gets to that front door, and boy, I have to run to get there. I just can't hold it anymore. I used to be able to hold it. I was a teacher. I was like a camel. I could hold it forever, and now I can't. That's called urge incontinence. And again, wonderful options. We have a lot for that. There are some holistic approaches. So there's a pumpkin seed extract that can be helpful. So that's nice for the person who leans on holistic approaches. There are medications that have gotten much better that don't have the side effects that the others did. The old side effects were a concern. Some just pesky side effects like a dry mouth and dry eyes, which are frustrating. But also we have to be so careful. Some of them also had cognitive side effects, and that's a little scary. So we have to be super careful with those, especially as we get older. We all have to ask if any medication has any cognitive side effects. In other words, that it'll affect their memory and their mental acuity. So we have to be careful. The newer ones don't do any of that, which is very exciting. So really, really safe, and they're effective. If somebody says, I don't want pills, I just want help, but I don't want to get into prescriptions at this point in my life. Neuromodulation, very interesting. We do a program here where you come in once a week, and believe it or not, by stimulating the posterior tibial nerve, it just wraps around the ankle by literally putting a little stimulator behind your ankle. So the person, they come in, it's kind of funny that they're like a little coffee klatch. These women come in, they schedule at the same time so they can chat. And there might be 6 of them in our room at one time. They're all sitting there. They pull up their pants, and we put up a little thing around their ankle, and it's a stimulator. And by stimulating that nerve once a week for 12 consecutive weeks, we see a significant impact on urinary frequency, urgency, getting up at night to urinate. All of that improves. It's really interesting. This is so successful that the limitation is coming into the office. That's our nerve stimulation program in the office. The limitation is getting into the office for some of these women because they don't have a ride or they don't drive. So there are home remedies now too. So this is an area that's absolutely exploding in our field because it has been so successful, but we want more access. So some of these women will be able to do this at home. So that's great. What that can also, the other treatment for this actually is, we're going back to that vaginal estrogen again. And the vaginal estrogen does help with overactive bladder symptoms, again, by just nourishing the tissue, which again is the vaginal lining, and it's also the lower portion of the urethra and the bladder. Those two areas, your vaginal canal, the vagina, and the urethra, the tube you urinated, they were one tube in gestation. When we're about 7 to 8 weeks inside our mother's womb, they were one tube. And then embryologically, they split and become 2 different things, the vagina leading over to the uterus and the urethra leading to the bladder. But they were one at one point. So they have the same embryological origin. Therefore, they're both estrogen sensitive. And that's the big point. People have to realize you're really going to benefit your bladder function and your vaginal function by using vaginal estrogen. And that leads me to a point that's so very important is now, this was big. In our world, the earth shook about 3 to 4 weeks ago. In our world, meaning the urologists and gynecologists who do this stuff, the earth shook when our organization, the American Urological Association, finally came out with a guideline that addressed GSM, genitourinary syndrome of menopause. Guidelines are in every field. Your cardiologist has guidelines that say best practice for how to manage atrial fibrillation. And your colorectal person has one that says best practice, how do you manage colon cancer, or how do you manage irritable bowel. In our field, we have guidelines for how to address kidney stones and how to address prostate cancer. I almost fell off my chair when the latest guideline came out in the mail and in their email, and there it was, management of GSM. I was shocked because we've been asking for this for probably more than a decade. And there it was, right on paper, assuring women and men and the practitioners, especially the gynecologists and the primary care physicians, addressing these issues, the vaginal issues and the UTIs with vaginal estrogen is safe, safe, safe. And you no longer say no to the woman who has a history of breast cancer. You no longer say no to the woman with a history of uterine cancer or with a family history of breast. The local application of vaginal estrogen is safe, and there's the papers to support it. So at least these women and practitioners can feel more comfortable instead of feeling like, oh, I'm uncertain, I feel like there could be risk. There's no risk to vaginal estrogen. Now, here's the only little point where earlier you were saying some of this could make you angry because it feels like so much of this should have been spelled out for us, and we've been either missing information or we've been misinformed. This one might get you a little steamed. It's frustrating for us. When they receive, so we go through all this education. I spend a lot of time with my patients saying, please understand the safety of this. I really want you to do it. And I finally get her to say, are you sure, Dr. Jordan? I'm counting on you. I say, yes, it's safe. Go ahead and get it. They go to the pharmacy. They pick up it comes in a box, the tube of estrogen, and there's a tube and a little applicator. And they look at it because they're good. Our women are smart and they're savvy. They look right at it and it says, caution, estrogen has been associated with breast and uterine cancer. And the husband looks at it, or the partner,
Right, the black
or the
box
sister,
warning.
or the whoever, and they say, Ma, you're not using this. It causes cancer. And they throw it right in the garbage. So, black box warning. So our leadership has gone to the FDA repeatedly every year for probably easily the last 6 or 7 years. And when they go to the FDA and they talk to the leadership, this just happened. We had a wonderful conference a week ago with all the leaders in this field. I mean, really, really smart, incredible people at all levels. Many of them practitioners in different fields, orthopedists who are talking about the effects of osteoporosis on women, which could have been prevented with their estrogen replacement, all of that. So it was a big menopausal discussion. And this came out over and over. And one of the people sitting in that room was somebody who's tied in and has a direct effect on the FDA. And they said, please, this is a disaster. And it is so unfortunate. And so there are no data to support an association between vaginal, I'm talking again, I want to be very specific here. Vaginal estrogen, the local application of estrogen, has never been associated with increased risk of any of those cancers. But somehow it got into they just simply took the label from systemic estrogen, kind of slapped it onto the creams. It's shameful. And therefore we have to, we do our education, then we have to untwist this whole thing. It is so frustrating. We're hoping that's kind of the next step. And I think we got some real traction at that meeting. It really was at a very high level. And everyone who does this and is respected in the field has said, please. I mean, they'll say, the person from the government just said, what is your wish list? And many of them raised their hand and said, please, you have got to remove these labels. It is very, very misleading. And it's not based on any fact. So there was a recognition that this is a big mistake, and that it really does a disservice to women who are trying so hard to address these issues. And again, in the government, everything is about kind of the dollars. So, okay, we can speak to you very directly. How many, and it's a huge number, how many women are coming in each year with urinary tract infections and then on to urosepsis? The dollars spent on these UTIs is staggering. And that can be very easily prevented with the use of of the local estrogen. And until you get that label off, we're not going to get the widespread use. People are not going to accept it. So we're hoping we get that last step. But this is all it's very upsetting.
How did it get to the point where people say it's so dangerous, and yet it's helping so many women?
Yeah, it's a fascinating story. It's an upsetting story. And if I had to summarize it, it was the Women's Health Initiative is talked about all the time, but it's a 2002 study that had very good intentions, your mother, maybe, but many people's mothers were given, everyone got estrogen replacement back in the 50s and they felt fabulous. And a lot of them would come in and they say, oh my God, my mom, she was great. She was rocking it. They looked great. They felt young. It's just when they started to transition, their doctor just handed them over the Prempro or the Premarin, a systemic estrogen, and they felt fabulous. They looked young. Their skin was great. Their hair was thick. They had they had mental acuity. They didn't have brain fog. They didn't have night sweats and hot flashes. I mean, it was terrific. And they said, what are the effects? Or does it have some positive or negative effects on heart health? There was a question of helpful. They were actually thought, is it heart protective or not? So to study that, they deliberately studied a more advanced, an older population. So the design of the study was skewed late. So as a result, when they did it, and there's a lot of nuances to this, how they did it. The Prempro these are synthetic hormones. Today we don't even do that. We use bioidentical. So there's a lot of not so much flaws in the study, but the study design led to a lot of misleading stuff. But the bottom line is this: once they saw a little blip in heart attack and stroke, boom, the whole thing got shut down. I mean, in medicine, people talk about this as being one of the most dramatic changes, where the estrogen prescriptions dropped precipitously. It was a huge hit financially for the companies that made it. There's a very ugly sort of overtone to this about what was going on in sort of pharma, and that's sort of a separate story that's not too pretty. But the most upsetting part of this is that the women in the transition years, and this is why I always say women who come in to see me at the 53 or they're 48, 49, 50, all the way up to 65, 48 or 45 to 65, that's a very special group who will benefit, for the most part, all of those women, unless they have something unusual, a genetic predisposition to clotting or something odd. But if they're the average woman in that age group and they're transitioning, for the most part, systemic estrogen will be protective against heart attack, protective against stroke, protective against colon cancer, protective against osteoporosis, and protective against Alzheimer's disease. That has been established. And what happened in that study is when they shut things down, they just said, done. We're not going to prescribe it. We have, and this is the dirty, ugly truth, but it is true. There's a generation of women who were deprived of the estrogen replacement, and we lost them to heart attack and stroke and Alzheimer's and colon cancer and the consequences of osteoporosis. There's a generation of women. The numbers are not small. It's tens of thousands. And that's the dirty little secret. And so it's a study that is talked about a lot now. People who are study it realize, wow, if you go back and look at the data, and there was a little apology. It happened 17 years after the study came out, a little in JAMA, in the Journal of the American Medical Association, saying,
So sad.
sorry, when we reread the data, there are women who would have benefited from this. And unfortunately, that negative impact has stuck. And for whatever reason, we still have to untangle that and say, hear me. That's old, the data, now that it is reinterpreted, and there's a lot of studies, but it's amazing how hard it is to untwist something like that. It's amazing how the bad news sticks. And these women, I see women who are 82 years old. She's been in the hospital 3 times with urosepsis. And I say, please. And she'll say, nope. I heard it's associated with breast cancer. I think, oh, please, you're not going to get breast cancer at 85. I promise you. Really, you're not. You have no history, but you are going to. You may succumb to one of these infections.
I want to talk about
it's a lot of education.
What your opinion is of the vaginal tightening, procedures that women get cosmetically in some of these clinics.
Such a great question. So we have an arm that does this. And I came to this because at one point, and I'm very proud of my leadership in my office, the corporate came along and said, just Dr. Girardi, you have a big practice of women. What are we not doing well? And I said, well, we're not doing menopause too well. And they said, do you want to do some extra training? So I said, I do. And I went to California and I did an extra vaginal fellowship. It was wonderful with a guy named Red Allensott. He's superb. He is a cosmetic gynecologist. So I went out there to California to check this out. My eyes were open, and by the end of the week, I was feeling very differently from the beginning. When I first went in, I wanted to see some of the surgery, because the surgery were things that I was doing, but he had some really neat techniques, and I learned a lot. So just how to correct the dropped bladder and how to correct the dropped rectum, these true, really bad vaginal prolapse, and he does a beautiful job. That's why I went. But the other stuff that he does as a cosmetic gynecologist is tightening, labiaplasty, cosmetic gynecology to make it look prettier, to make it tighter for vaginal function. At first, I thought, sort of I was mixed because I thought the same way I feel about plastic surgeries. I like women to embrace that everybody's beautiful and that variation is more interesting than everybody looking the same, and embrace your differences. And when it comes to vaginal anatomy, I always say to them when it comes to the labia, et cetera, that asymmetry, a lack of symmetry, is really the rule, not the exception. Most people have one side's bigger than the other. All of that is variance of normal. No one should feel abnormal or deformed or whatever. And I thought, who are the women? And then by the end, I really had a different appreciation. Women were coming to him and saying, for me, functionally, this is a problem. I feel nothing during intercourse. It feels like a big, wide open gap. I pretend because it's important to my partner to have this intimacy, but I just don't feel like I'm getting anything out of it. So he has techniques and he has machines and things like that that help. There's a laser machine called the Mona Lisa that does a CO2 laser to help with moisture. And there's also radio frequency is something that also helps in that area. My feeling about it is this: if it is presented in an honest fashion, we do some of those procedures here. I am very, very honest with you. I say, listen to me. The standard of care in this country to start with is you want to be starting with a vaginal estrogen, a cream. It's a heck of a lot cheaper than paying thousands of dollars for a procedure. But if you're someone who already did the estrogen and it didn't work, or it was kind of goopy and messy, or despite all the education, they just don't feel comfortable saying, I know, I hear you, Dr. Girardi, but I got to tell you, I'm so freaked out by the fact that my best friend died of breast cancer, or my mother suffered with, I don't care what you tell me, I'm not going to accept it. And I say, fair, I'm not going to twist an arm. So I'll say, we do have alternatives, but they are cash, they're not cheap, but they are effective. And I do find they really do help. You can restore moisture. You can restore some of the laxity. You can restore some of the cosmetics without doing cosmetic surgery, and it restores some of the plumpness of the tissue. My patients love it. Also, there's this condition called lichen sclerosis, which is a skin condition that is exclusive to the women's labia, the lips, and to men near the foreskin area. And it's a brutal condition. It's very unfortunate and causes a lot of pain. The tissue becomes very compromised and sort of ulcerated. It's miserable. And we find these treatments are really quite good. So we can add platelet-rich plasma. There's different things we can do. But as long as it's presented in a fair fashion, for me, it's not too different from my fertility practice, where that's a vulnerable population, just like our infertile couples. And so those couples are so desperate to have a child, and we have to be very careful to make sure we're giving them evidence-based medicine and presenting things that work, because they're so vulnerable that if you walked into a clinic and they said, I've got 100% success rates by taking ginger root and rubbing it on your head, some of these vulnerable couples, they'll do anything because they want that baby so much. Similar in this area, there's so much pain with vaginal intercourse, or they've had so many difficulties with the appearance bothers them, whatever it may be. They're vulnerable. So you just want to make sure you're very honest in the presentation, spell out for them your success rates and how they compare nationally. And I just try to be as upfront as possible. And I really do spell it out by saying, listen to me, evidence-based, what do we have clinical studies for? Well, the estrogen cream has been shown to help.
Oh my gosh. Wow. All right. That's it for us. A big thank you to Dr. Sara Girardi. Dr. Girardi, it's an honor to have you on the show. I mean, you are a beacon of hope to every woman listening that they can dance again, they can go running again, they can live a normal life again. Yeah. So thank you so much. I'm Jill Conway, and thank you for listening to the show celebrating incredible women like Dr. Girardi. I hope you are inspired to pursue your own goals, believe in yourself, and dream bigger. Your voice matters, and your story can help others. I hope you join me next time. Share this podcast with a friend.